my name is Eric Skarsgård. I'm privileged to present the next Journal of Pediatric Surgery top educational content talk to be given by Dr. Hannah Piper, Associate Professor of Surgery at the University of British Columbia and the Surgical Director of the Intestinal Rehabilitation Program at BC Children's Hospital. As pediatric surgeons, we frequently find ourselves in the operating room with babies and children facing massive intestinal resection from neck, gastroschisis, or midgut volvulus, who survive to face the potentially devastating consequences of intestinal failure. Dr. Piper is here with a message of optimism, reflecting advances in knowledge through research and the success of multidisciplinary rehabilitation programs in allowing these children to survive, thrive, and achieve enteral nutritional independence. To support pediatric surgeons in making optimal clinical decisions, the APSA Professional Development Committee thought you should be aware of the improving prognosis for children with intestinal failure.
I want to thank APSA for dedicating a tech talk to children with intestinal failure. Although we often think of children with intestinal failure as requiring more medical and less surgical management, as pediatric surgeons, we're often some of the first providers caring for these patients, and sometimes we're forced to make difficult decisions about the direction of care. Occasionally, we'll find ourselves mid-operation having to stop and talk to families about what life might look like for their child should we choose one direction or the other. And these discussions are always very difficult. As such, we owe it to ourselves, to the patients and their families, to provide the most up-to-date information that we can, recognizing there are always exceptions. What I hope to do over the next 10 minutes is emphasize the progress that has been made in the management of these patients over the past couple of decades and subsequently their outcomes. And I also hope to highlight how, as pediatric surgeons, the decision-making that we do intraoperatively, as well as our documentation, can directly impact both prognosis and the strategies that we use to manage these patients long-term. I have no disclosures. I think it's important that we start by understanding what we mean by intestinal failure in pediatric patients. So this is a broad definition that we use to define any child whose intestinal function is insufficient to support normal growth and development. And most commonly, this is due to short bowel syndrome. And short bowel syndrome is caused by things that we're very familiar with, such as necrotizing enterocolitis, gastroschisis, small bowel atresias, midgut volvulus, and sometimes Hirschsprung's disease. Short bowel syndrome occurs in as many as 1 in 4,000 live births, and it's much more common than this in premature babies. Other causes of intestinal failure include dysmotility disorders and mucosal-based diseases, but these are much less common, and sometimes as surgeons, we're not as involved in those patients. However, regardless of the cause, any child who requires 60 days in a row of parenteral nutrition support due to a primary intestinal problem is considered to have intestinal failure. The management of children with intestinal failure has changed significantly over the past 20 years, and as a result, the outcomes have also improved. Currently, we're seeing as many as 90% of these children surviving in the long term, and anywhere from 50 to 85% are getting off parenteral nutrition and staying off parenteral nutrition and achieving enteral independence. And this even includes children with ultra short bowel syndrome who have less than 10 or 15 centimeters of small bowel, where as many as 50% of these children are getting off and staying off parenteral nutrition. And these results are being reliably reproduced across North America and much of the developed world. And so what has changed? The improvement in outcomes have been due to a multitude of factors that have been fueled by some very important research, which has increased our understanding of intravenous lipid emulsions, preventing hepatic cholestasis, preventing sepsis, and optimizing intestinal adaptation. But many of these outcome studies have had a common observation, and that is that children who are cared for by a multidisciplinary intestinal rehabilitation program tend to have better outcomes. And so what does this mean? Many children's hospitals across North America now have a dedicated intestinal rehabilitation program. And typically this team will consist of a surgeon, a gastroenterologist, a dedicated dietitian, a nurse or a nurse practitioner, oftentimes a social worker, sometimes a pharmacist, and or an occupational or physical therapist. And this team typically will cover patients' care when they're both inpatient and outpatient. And the structure allows for continuity of care and expertise as the children transition from parenteral nutrition to enteral nutrition. And these teams also allow for improved communication with families and children and among providers. And what we have seen is that children who are cared for by a multidisciplinary intestinal rehabilitation program tend to have better outcomes. And they have a lower incidence of hepatic cholestasis, they have fewer septic episodes, and they have a higher likelihood of weaning from parenteral nutrition and meeting growth targets. And so the take-home point here is that if you are taking care of a child with intestinal failure or who you think may have intestinal failure, an early referral to an intestinal rehabilitation program is a great idea. And if you don't have access to this at the center where you work, the good news is that remote consultation is even more feasible now in the current era than it ever was before. This past year has shown us that there are a lot of creative ways to get a remote consultation when needed. So despite these improvements in outcomes, there do remain a subset of children who have limited potential for enteral independence. And these children typically need to stay on parenteral nutrition for the long term. And usually these children will be referred to an intestinal transplant center for evaluation. This is the minority of children, and as you can see, the number of small bowel and multivisceral transplants being performed annually in children in the United States has decreased significantly over the last decade. And currently, there are fewer than 40 transplants being performed annually in children. And the good news is that the outcomes have also improved in this time period. We're now seeing 10-year survival for patients greater than 60%, and for grafts themselves, approximately 50%. So for the few patients who need this, consideration of an intestinal transplant is important. The final thing that I want to talk about is how, as pediatric surgeons, our intraoperative decision-making and documentation are very important for both prognosis and for the long-term management of these patients. What's important to remember is that the most reliable predictor of being able to get off parenteral nutrition is small intestinal length. And this has been shown in many studies, and it makes sense. And so as pediatric surgeons, we need to try our best to save as much small intestine as we can. But not only that, it's important that we document the intestinal anatomy for the child at the end of the operation. Having this information is very helpful for conversations with families about prognosis and for tailoring management to that specific child. And the best way to do this is to measure the bowel length during the surgery. And this can be done by using either a silk tie or an umbilical tape, and starting at the ligament of Treitz or at the pylorus in the setting of a rotational anomaly, and measuring along the antimesenteric border. We're also realizing that both the ileocecal valve and the colon are important in achieving enteral independence, and that their importance is probably independent of small bowel length. So as surgeons, we need to try to save the ileocecal valve when we can, and also save the colon, and put the colon back in continuity as soon as is feasible. So what I hope you'll remember from today's talk is that children with intestinal failure, for the most part, do very well. We're seeing as many as 90% of these patients surviving in the long term, and up to 75% getting off and staying off parenteral nutrition. As surgeons, we need to try to save as much intestine as we can and document this clearly in our operative reports. And probably most importantly, we need to refer early to an intestinal rehabilitation program. We've certainly come a long way in the management of children with intestinal failure, and as pediatric surgeons, we will continue to have an important role in the lives of these children.
Well, good afternoon and good morning. I'm Patrick Javid, the Surgical Director of the Intestinal Rehabilitation Program at Seattle Children's. Hannah and I first met in the laboratory of Dr. Tom Jaksic in Boston, and it was through Tom that we developed our passion for taking care of children with intestinal failure, and we're really happy that it's a topic for discussion today. Hannah, that was a great talk, and we've got the next 10 minutes to talk about pediatric intestinal failure. And I'd like to start by asking you, the outcomes that you presented are really remarkable. It's been a big turnaround in our field over the past 15 to 20 years. What do you think are the key factors that have really led to the improved outcomes in our children?
Yeah, thanks, Patrick. And I agree with you. I miss those old days in the lab in Boston. They were fun times, and definitely led to our passion in this field, which you're right. I mean, it's really taken off, and kids who used to die primarily from sepsis or liver failure, that's no longer a major factor anymore. And I think, as you know, that's due to many things, but definitely we have to talk about the advances that have been made in preventing progressive cholestasis and eventually cirrhosis, which used to be really the rate limiting step in the survival of these kids. So I think the advances that we've seen in different types of intravenous lipid emulsions, we used to just have intralipid available to us. Now we have mixed lipids like SMOF or the fish oil-based lipids like Omegaven that have really changed that course, in addition to other changes in parenteral nutrition that have resulted in less damage to the liver. And then I also think just our attention to preventing infection has really helped too. So now the kids have a chance to give themselves the time they need for their intestine to adapt. And as a result, we see better outcomes because most intestines do adapt with time, as long as they're not sick from other things. So I think that's made a big difference in the outcomes. We do have a question in our chat, so I'll ask that to you, Patrick. It says, are there any protocols for managing chronic intestinal pseudoobstruction that then becomes intestinal failure? Maybe how do we deal with those types of patients, which is certainly a difficult population for us?
Yes, that is a very challenging population, and it can happen at different ages. Definitely younger children, but we also see teenagers who may have mild pseudoobstruction that transitions to sort of full intestinal failure as they get older. I don't know that there are defined protocols in the field, and I think in pseudoobstruction, each patient is very different. You'll have the patients that have pseudoobstructive episodes that we may not exactly know what triggers them, where they need to come in for bowel decompression and gut rest, and that can last sometimes for days to weeks. What we've seen here is that some of these children, as they get older and as we realize they really have pseudoobstruction with full intestinal failure that's not going to get better, those are the patients that we start thinking about intestinal transplantation in the long run. And those are the patients that are interested in it when they get to their teenage years, and we're following some of these kids into their young adult years, college years. So protocols are difficult for these patients, but I think each patient, we need to give them what they need in terms of gut rest, decompression, and long-term transplantation.
Yeah, I agree. I mean, I think that's the most challenging population. And now that they can live for long periods of time on PN, it does become a question of quality of life. And when you consider transplant versus just staying on PN for the long term, and many of them need repeated hospital admissions. And so that really factors in. So we have another question. It says, when we talk about intestinal adaptation, how long does this take? And does it depend on bowel length? So what do you think, Patrick, about that?
Well, I think it's partly related to length, but it's definitely also related to function. So, we have patients, if all of your bowel worked, it would be very dependent on the length, but it depends on a few things, though. The function and motility, absorption, I think what bowel you have remaining. If you do have the luxury of having some distal ileum, I think that adapts better. And we have some scientific data around GLP-2, which we may get to, that backs that finding up. I think the more colon you have, the better, obviously. So I think, when we look at adaptation, not just length, I would say function and what bowel you have remaining. Hannah, what do you think about that?
I agree. It's a term that we use to encompass a lot of things that happen in those first couple years, particularly in kids with true short bowel syndrome. We can make that distinction between the pseudo-obstructive kids, for example, or just kids who have lots of length, but their intestine doesn't function versus the ones who've had a major resection. And I do think that it does vary from patient to patient for sure, but we think about it as that time when they're transitioning from full parenteral support to enteral support. And there's a lot of things that go into it. So unfortunately, it is hard to predict. And that kind of leads into our next question, which says, does the improvements that we've seen with parenteral nutrition change the discussion that we have with parents of preemies with near total or total neck? And I think it does, because as I mentioned before, many of these kids now are surviving. And we know that their intestine will adapt if they're given a chance, if they don't get sick with other things, if they don't have a lot of other more comorbidities. So I really do think these discussions have changed, but one of the trickiest parts is just having such a big discussion with a family in sort of a short period of time when they have to make decisions around that. What do you think, Patrick?
I agree. I think it's, the discussion is not will they survive? It's what survival will look like in the long term, and I think it's probably the best conversation, and it's not in an ideal setting or an ideal timing, but revolves around what their care is going to look like, and it's going to be, it's going to involve lots of clinic visits for many years, and maybe forever, maybe an admission or two every year for bloodstream infections and central line changes and things like that. It's a long process, and we explain that to families that somebody had asked that earlier in the question. This isn't months. In many of our kids, it's years, but the outcomes are good even years out for attaining enteral autonomy. And I think that's important to remember. And for some families, that's, they want that. Some families, depending on their family structure, when you explain that can have an effect on them as well.
Yeah, and I think it's hard not to let our own bias enter those conversations as well sometimes, because we have our own opinions about, how they're going to do and what that might look like. But it is really hard on the families sometimes. And I think that's sort of the next big frontier, is how it impacts their quality of life long term.
Right. There's a question about refeeding in the chat, and I think, Hannah, at your institution, do you refeed distal stomas frequently in these kids that maybe they have temporary intestinal failure where we're just waiting to get them back in intestinal continuity?
Yeah, we don't do it routinely, although I do think there's some value, and there's more evidence coming out that it's safe and can be very effective. What about you guys?
Same here. I think it's tricky to maintain it. And I think with our new lipid strategies, we can prevent parenteral nutrition-associated liver disease in the vast majority of our patients, whether they're temporarily short or in the long term. And as you mentioned, between lipid restriction and SMOF, and SMOF is our first line now. In fact, I think in all of our preemies in the NICU, but definitely in all of our surgical babies in the NICU. And so I think we can prevent that, and that again is another way to provide time for the intestine to adapt, or time to get them to their stoma closure.
Yeah, absolutely. And I think that's really been the game changer. And I think the future for these kids is bright, and there's a lot of good research going on that's going to change things in the next decade too.
Yes, absolutely. Well, it's been great to talk with you, and hopefully, we have a couple seconds. I should put a plug in. We have a multi-center quality of life study ongoing. Hannah and I are part of it. 14 centers getting together, and we've enrolled 150 patients already. So I think that's the future of our field, is going to be multi-center prospective studies.
Absolutely.
Well, that was a great conversation about intestinal failure. I learned a lot. I thank Hannah and Patrick for that conversation. It was great. Let me talk to the people on the screen right now. I always struggle when I go to do a necrotizing enterocolitis case or a midgut volvulus, and what we're supposed to save and what we're supposed to resect, and how do you decide that? So I'm maybe putting you guys on the spot. What's your clinical, how do you approach those cases where there's a, mid-gut catastrophe going on, and what's your approach?
I think the mantra of save as much bile as possible and try to save the ileocecal valve if you can is critical. And so in that situation, I drop or put clips on and drop it in and come back another day if it's not clearly dead. Now, if it's clearly dead in the product, you remove what you have to. But if there's questionable viable bowel, I think it behooves you to clip it, drop it back in, and come back in 24, 48 hours, depending on how the patient's doing, and see if you can salvage any more of the bowel. Jamie, what's your take on that?
Yeah, I absolutely agree. I think putting a silo on or an Epithera and coming back as soon as you need to. If the patient starts to clinically deteriorate, going back even sooner than initially planned. I think one thing that we touched upon during the talk is this is a hard conversation to have with families in kind of the rush of getting these patients to surgery right away. And it's a hard conversation to have when you come out of the operating room too. And I think that was really educational, really informative. But I don't know if you guys have any suggestions for how to talk to these families too, as you go through this process with them.
I think you bring up, I think that was the highlight for me, what you just said, is these conversations you have with the family and the time that you're doing it. It's during a extremely stressful period. Most families are not in the medical field, and it's so hard to envision what the next 6 days, 6 months, 6 years are going to look like for these children. And you try to paint a picture of what that entails, but it's impossible for someone who just had one of the greatest gifts of life, born in probably in the last few days, now in a struggle for that child's life, and then making these huge decisions. It's really a tough situation. And I think I'm learning every experience how to deal with it, but I haven't mastered it. Dave, have you?
No, absolutely not. As a parent, it's your worst nightmare, right? It's your worst thing you can imagine. And I think this also goes into support that dropping in temporary closure, whether silo or a vac or something like that, and giving some time for the the parents to realize the gravity of what's going on and process it. And I think it's multiple discussions. And, we here use a NICU team and go together and talk to the NICU as a team with a unified front. And it's having those multiple discussions. Jamie, how about with you?
Yeah, same. I think having them hear it kind of multiple times from different providers. I think in some situations, having the silo in place and everyone kind of being able to see what the intestine looks like too, when you're still trying to make that decision. And sometimes the parents kind of seeing what it looks like. But yeah, I couldn't imagine having someone have that conversation with me. And really even as a physician, picturing what that would look like, constantly going to clinic visits. But I think it's an interesting point that the field has evolved so much in the last 20 years. What's going to happen now in the next 5-10 years, and how will this conversation be changing? And even for the patients we're operating on today, how will their lives change, and how will our therapies improve over the next 5, 10, 20 years or so too? So it's a difficult conversation to have, and to give them that advice going forward.
Yeah, it's pretty incredible. I've been attending APSA since the early 2000s, and I remember now just reflecting the talks about lipid preservation and all the strategies of preserving function. And now here we are living it. Every time I walk into the NICU, we talk about SMOF and looking at what we're doing with our feeding regimen. So it's pretty incredible how far we've come over the course of the last couple of decades. So incredible bench to bedside. I think APSA has provided that over the last decade. And I think we have time to now transition. So I think our next talk is one that's going to blow everyone's mind away. It is very different. It is don't expect a regular top educational content talk this time. This is going to be a totally new venture, and it's going to be awesome. So scroll down to the bottom of your screen, and this is not recorded, and click the button that says to attend the next session. See you
See you
soon.
soon.